anxious because everybody was emailing her thinking that y'all were fussing. And I said, they're not fussing. They're just, it was fresh in their minds. And they wanted to make sure that they sent the email about the question at that point. But, you know, sometimes we can't get back to you immediately. Give us time to look at the questions. We did throw out 2 questions. And right off the top of my head, I cannot remember which ones they were. I cannot remember. But anyway, we did throw out 2 questions, and there was one that we took 2 answers for. But overall, everybody did amazing. I was very, very proud of you guys with everything that's going on, all the COVID crap, which I'm sick of. And I know everybody else is tired of it too. But I think you guys are doing a great job with attending classes and going to clinical and doing your assignments. I'm so proud of all of y'all getting in your assignments at the right time. And I just wanted to tell you that I was proud of you guys. This has been very difficult. You've had 112 was a beast and you survived, and 113 is a little bit more, I think it's better. I think it's better and more fun. So that being said, all right, somebody told me that the question she threw out was the one about the glucose tolerance test. There was a glucose tolerance test, and I think the reason I think I remember now, it had something about the total grams, and she felt like that she didn't discuss that in depth enough, guys. So
okay. That makes sense.
Yeah, she said she didn't go into detail about that. So she felt like that would needed to be taken out. And then the Trendelenburg, which I can't remember the Trendelenburg.
I think it was something about the woman, she's at a visit and she's feeling lightheaded, dizzy. What should you do?
But she told us by mouth that it was the left line position and Trendelenburg position.
Right, yeah, because I was looking for left line.
That's the question here.
But didn't she put right side?
Yeah,
Right side.
it was right side. Mm-hmm.
Yeah.
She did put right side, but that was not correct.
And it should have been
Right.
left.
Left, yeah.
Right.
I was looking for left.
But like I was telling her, a lot of times in pregnancy and in labor, the ideal position is the left side. Okay, so when you're answering a question with anything to do with a mom having difficulty in labor, in the position that you want to put her in, put her in the left side. It's very, very important that you put her in the left side. But when you actually get into seeing labor, that left side may not work sometimes. So you're not going to keep them in that left side if I'm still having issues with the fetal strip. And we're going to discuss the fetal strip in just a little bit. So there may be times that you have to put them on the right side, but the reason why the left side is because it's not compressing the vena cava. I don't know if she explained that to you, but the left side is not suppressing or compressing the vena cava. So it's allowing for more perfusion to happen. When you get them on the right side, it has a tendency to push on that vena cava more. So it still gets adequate perfusion, but it has a tendency to not do as well. So that is all I'll say about that. Okay, let me tell you I'm getting ready to start the PowerPoints, but I want you to, those of you that take notes, one of the ways that I have found out to help you with the different stages of labor, because there's 4 different stages of labor. If you will get like a piece of paper and put stage 1, and then put the active and the latent and the transition down, and then right beside, make sort of like a chart. It's okay, this is what's happening with the first stage of labor in the active stage or the latent stage. The patient can be dilated to this, and then how is the patient responding? How is she acting? And then do another column with the nursing interventions. I think that's going to be a great way to help you organize what you need to know about that. Okay. This is the first time I have used your book. I don't particularly like this book. I don't like the way it's set up because I would have set up my PowerPoints a little differently. So that's why I said it might be easier to do that chart, because we're going to talk about what happens dilatation in the first stage. And then we're going to talk about what the patient might be doing. And then we're going to talk about the interventions at different times. So if you make a little chart, that may help you as well. There are some charts in your book that helps with that as well. Okay. Am I going to post the lecture recordings on Blackboard? Actually, you know, I have, okay, let me just do this. Okay, record. Okay, I'm recording.
Can you quit?
I did it. I did it. So, y'all, I'll do that and I'll post that for you guys. All right, so one of the first things I want to go ahead and share my screen with you guys, but guess what we're getting ready to do? We're getting ready to have a contraction. Those of you that have already had a baby are like, don't want to have one of those again right now. The things that I'm going to start off with is talking about childbirth preparation. There's a lot of reasons why we do. Can y'all see my screen?
Yes. Yes.
Good. All right. So there's a lot of reasons why people go to childbirth education courses. There are lots of them out there. The most common one that you're doing is Lamaze. I was a Lamaze instructor for about 7 years. And so when you think about a Lamaze instructor, what do you think the purpose is? Somebody needs to mute.
Maybe purpose good breathing techniques in.
Good breathing techniques.
No.
But those breathing techniques are going to do what?
Help the laboring mother to control, like, maybe to like be prepared for like how to breathe through contractions and what to do and stuff like that. Just the overall, like, you know, correlation between contractions, knowing how to breathe, taking your breath. So you know, you're ready, your body's able to withstand this labor, you know, getting
right.
Yeah.
Ms.
So
Walker,
the bottom
can
line,
you mute everyone's mics, because I can't hear like anything that anyone's saying.
okay, so everybody mute yourself unless you want to talk. Everybody muted now?
I think so.
Tracy, are you muted? No, you are. Is everybody muted?
I think
Okay,
it's
so
Susan's mic that's unmuted because her thing keeps popping up on my
who?
screen. Susan.
Hey, Susan, are you muted now? There might be a way I could mute people.
Yeah, I don't think she's at her computer either.
Okay, so she needs to, Susan, you need to mute.
I think she muted now.
Okay, good. All right, good. So one of the biggest things that as a nurse, as you think about people going to these preparation classes, is about education, right? They're trying to learn what to do. I'll never forget when I told my husband, oh goodness, when I was pregnant with my daughter, we're going to Lamaze class. Well, I don't want to go to Lamaze class because I know you know how to breathe. Well, yes, I know how to breathe. But the key to that breathing is to help you learn how to control your breathing and help you decrease anxiety. That's one of the biggest things, because what I used to tell this all the time in my Lamaze classes. Let's say that we are out in the front yard playing and our 3-year-old throws a ball in the road and he runs to the road as you are screaming, don't run to the road. You start running after him. You see a car coming. You know that that car is going to hit your child. as you're running after your child, you run into a huge boulder on your bare feet and you have busted up your foot and it's gushing out blood. Once you get to your child, spank them, hug them first to tell them don't run in the road, and then hug them because they're okay. Do you think that your foot was hurting as you were running after your child?
No.
You weren't thinking about your foot, were you?
Right. Adrenaline was kicking in.
Yeah, I got to get my baby. I got to get my baby. So, but as soon as you get your child, you hug them and then you spank them and then you do what you need to do to them and get them out of the road and get the ball. What do you think your foot's going to start doing?
Hurting?
It's going to start hurting, isn't it? So basically the reasons why we try to teach the different breathing techniques is to trick our brain. Because there's going to be some, I mean, we're used to and breathing normally and we don't even think about it. But if we have to breathe differently, it's making our mind think about the breathing instead of the actual pain. Now, am I going to tell you just because you breathe these different pain patterns that all the pain's going away? Absolutely not. It's going to be painful. But this is the way to help deal with patients. Our patients help deal with the different ways of dealing with the pain. So what I want to do this morning is that we're all going to have a contraction. I want you to get your fist so I can get my timer out here. You know, I'm all about doing crazy stuff. If I can figure out how to get my clock and my timer. Okay, stopwatch. Okay, so what I want you to do is I want you, and we haven't really talked about how contractions work, but they go up, they start out low, and then they go up, and then they're really, really strong, and then they start coming down. So when I want you to get your fist up, and I want you to pull it into a fist like this. When I tell you that the contraction is starting, you need to start pulling that fist tight. And I'm going to tell you when it's the hardest it can be is the very, very, and you need to be doing this, you need to be doing it hard. And then it starts releasing as we go down, as the contraction goes down. Is everybody with me? So everybody now, Osmond, you are going to have a uterus.
Really?
Yes. The first time in your life, you're going to have a uterus. And here it is. All right. So what I want you to do is I'm going to start and we're only going to do this for a minute. Okay. Only for a minute. And I'm going to tell you when the contraction is at the hardest. I want you just to breathe normal. I don't want you to do anything else to try to decrease this pain. Okay. All right. You ready? The contraction is starting. So we need to be getting our fist very, very tight. It's getting harder. It's getting hard. Don't you breathe no extra way. I want to see pain. Pain, pain, pain. Oh my goodness, it's getting hard. It's so hard. Oh God, this hurts. This hurts. This hurts. This hurt. Oh my gosh, this is hurting. Oh, goodness gracious. Oh, it's at the strongest it's going to be. Now you can start releasing it. Oh, this hurts. Oh, my goodness. Oh, Lord have mercy. I just can't do this anymore. Oh, these contractions are hurting. Oh, my goodness. Oh, well, it's coming down now. It's a little bit better. Little bit better. It's almost over. Oh, goodness. This is, goodness. And gracious of me, this is okay. The contraction is now over. All right, who hurt? Was it uncomfortable? It was a little uncomfortable, wasn't it? I wanted it to hurt because labor hurts. And I want you to see what your patient's going. Now, we just had a contraction for 1 minute. 1 minute. These patients are getting contraction after contraction after contraction. So when we put into different kinds of breathing exercises, one of the biggest things that we want to do is we want to make sure that they take a really deep breath at the beginning of the contraction. And that's one thing that's so important. Does anybody know why taking that big, deep breath at the beginning is so important? Anybody know?
So they don't lose oxygen?
Right. Don't lose oxygen. But who doesn't lose oxygen?
The baby.
The baby. Absolutely. Because as soon as that contraction stops, O2 stops to the baby. Okay. So it stops to the baby. So you want to give that mama a big old deep breath. Let her take as much O2 as she can in at the very beginning to last her for that 30 to 60 minutes of that contraction. So that's one of the breathing exercises. Take a deep breath in at the very beginning. And then as the contractions get worse and as she progresses through labor, it's going to be a whole lot harder for her to control her breathing. One of the first things that they want to do is hyperventilate. They want to, and then they're going to hyperventilate. And then think about how long you learned an acid base. If they hyperventilate, what's going to happen to them?
Respiratory alkalosis.
Yeah. And who else is going to get some trouble?
The baby.
The baby.
My baby.
Yeah. They're going to be crazy. They're putting way too much oxygen to their brain.
Huh?
The mom's going to just lose her mind because she's giving herself way too much oxygen to her brain.
Absolutely. Absolutely. And then that CO2, what the heck's it going to do? It's going to start getting higher.
Mm-hmm.
So then she's going to pass out. And then is she going to be any good for that baby? No. So you're constantly having to think about two babies or two people, mama and baby. So one of the things that they teach you in no matter what childbirth class that you go to is that you take that deep breath at the very, very beginning. And when do you think you want to take another deep breath?
At the beginning of the next contraction?
At the end,
end.
of that contraction. So you're going to take a big one at the beginning and a big one at the end. So I need to tell them that I need a deep breath at the very, very beginning. And then at the end, I want to take another deep breath. All right. So we're going to have another contraction. So I want to just give you one breathing technique that, and I might have everybody turn on their thing so I can hear you. Unmute yourself just to see. I'm just going to give you another breathing technique that they do in Lamaze. The breathing technique is that normal breathing? It's not normal, is it? We're used to, but we're going to go. I'm going to make y'all big so I can see everybody. All right. So when we're looking at these or talking to these patients about this contraction they're getting ready to have, and I'm going to get your uterus back up, and we're going to have a contraction. And I want you to tell me, if I can get my phone going, I want you to take a deep breath at the very beginning. And then I want you to breathe. Okay. All right. Reset. Are we ready to have another contraction? Ready? All right. Here we go. Make that uterus tight. Make it tight. All right, contractions at the hardest now. Now it's going to start relaxing. Oh, it's hurting. It's hurting. Oh my gosh, it's hurting, but it's starting to relax some. Getting ready to relax at the very, very end. And the contraction has ended. All right, tell me how that felt. Did it make a difference? Were you concentrating on your breathing instead of concentrating on your hurt uterus?
Yeah.
Did you tell a difference? All
You're
right.
just more calm.
Yeah, you're more calm because you're sitting there focusing on the breathing. So I wanted to do that activity with you just to get us started to realize why we are going through all of these different breathing techniques. It's not to teach the patient how to breathe. It's to teach the patient how to decrease her anxiety and to help her relax, because guys, in labor, patients want to tense up. When you're in pain, what do you think you're going to do when you look at that foot that you hit that boulder? You're going to start tensing up, aren't you? And you're going to start, and it's going to start hurting more and more and more. So if we can give you methods to help you decrease some of that anxiety by the different breathing, that's going to help with that. So that being said, I did give you a list here of all the different preparation methods we have. Lamaze is the most common. You'll also see a Bradley is very common, but if you noticed in my PowerPoint, that's a 12-week session. Those people that participate in Bradley method are strictly have it in their minds that they're not going to need any assistance medically, i.e. medications, to help them through labor.
So are these the women that do it natural?
Yes.
Okay.
Don't want any pain medicine, anything. They don't want it. And that is their expectation of what labor is going to happen. That's another thing that you'll see that now when patients have Lamaze and Bradley, the other two are not really commonly seen around here, but they will come in with a birth plan. They will say, this is what I want out of my delivery. And most of them personally, or most of them will come in and say, I don't want any pain medicine. Okay. So you're saying that when you're in active labor and you are hurting and you can't get in control, you don't want me to do anything for you. You don't want me to give you any meds, nothing. And at the beginning of the labor, they'll say, yeah, don't want anything. But as they progress through labor, then they're going to be begging you sometimes that they want something for pain. And then you have to go back and say, well, you told me not to. This is in your birth plan. The moral of that story is, guys, patients have a plan. And you guys know more than anybody else that sometimes our plan doesn't always work, does it? These are things that we think are going to happen, but they're not. So they don't always happen. So one of the things that I try to do with patients when they come in and say, yeah, I don't want this, I don't want that, I want this, I want that, I always say, you know what? I respect this. I respect that you have a plan, and I will do everything I can to honor your plans. But I can tell you that if something comes up, because in the Lamaze classes, they don't talk, in the Bradley classes, they don't talk about, well, what if the baby doesn't like what's happening? Or what if the baby's showing signs of distress? What are you going to do? I've had people come in and say, I will not have a C-section. Will not have a C-section. Okay. And then we get into the labor, and then the baby's having fetal distress, and they're saying, I don't want a C-section. So you have to tell them that there are times that things may change in that. Yes, I will respect your plan, and I will do everything I can. But if that baby starts having trouble, I'm going to have to intervene. Okay, so be very open with them about that. Other things that you can do to protect or prepare for labor is a lot of body conditioning exercises. One of the most common is the pelvic tilt and the pelvic rock. So when you are telling these patients as they are going through their pregnancy, and we're going to talk about the pelvic area in just a little bit, that pelvic bones do so much when we get ready to go into labor. They move and they tilt and they do all this stuff to make room for that baby to come through. So if you assist the patient in doing pelvic tilts and pelvic rocks, first of all, does anybody know what I'm talking about when I say pelvic tilt and pelvic rock? You know what I'm talking about? Okay. When you get on, I cannot do that right here because I have on shorts and I'm not going to do it. Is it ready? So when you have the patient get on their back, lay on their back, put their knees up, put their feet on the ground and put their knees up, and then they push their bottoms up. Okay, so they push their bottoms up and hold it. And what that's doing is all those muscles around the pelvic area start strengthening. So they develop, it's like when you're working out to do a 5K. You don't just go in there and start, I'm getting emails, sorry. You don't just go in there and start running. You have to prepare, you have to work a little bit to strengthen up your muscles. And we have to do the same thing when we're ready for labor. The other thing is that Kegels, and I know all of you have Miss Beaver and everybody knows what Kegels are, right? So you Kegel a lot there, and all that's doing is helping you develop those muscles. So when we go into this, ready to have this baby, those muscles are good and strong, and they can assist and be ready for the pelvic area to move and the baby to come through. Other relaxation techniques, moms, I always ask them, what do you do to relax? I think one of the biggest things that I do, I love candles. I love to have the room darkened. And, if that's what they need, then get a candle, do the room dark. Another thing is I like to be massaged. I like to, if it's rubbing my hand, very light massage. Your head, you can massage their head and their face. And one of the things they don't like is for you to touch their belly with any strength there. When we get massage, I want somebody to dig and get me good and relaxed. But one of the things that is really, really common is called efforage. And that is a very light, you take your fingertips and you just rub the belly. It's called efforage. That is very, very relaxing for a patient that's in labor. They can do it themselves or they can have their partner do it as well. So that is so there's different things that you can do to help. You do whatever you need to do to help that patient relax and stay in control. Because once they start getting out of control, then their body's going to start tensing up and the body's not going to be able to do what it needs to do to get this baby out. Okay, so relaxation is the biggest thing. Helping them to relax with the breathing, efforage. Other things is I always think about the beach. So have them imagine that they're at the beach, or if they like the mountains, imagine that they're in the mountains in front of a fire, just sitting there drinking a glass of wine. Anything that they can to do relax. So that is the biggest thing that when we're talking about preparing these patients is relaxation and knowing that they've got to stay. Are these patients going to lose it? Absolutely. Absolutely. And we'll talk more about that stage that they're going to lose it in just a little bit. But we're going to do everything we can to help the patient relax. Does anybody have any questions about the different methods or the reasons why we're doing that? I'm smelling some Clorox. My mom's a cleaning. All right, so does anybody have any questions about that? Michaela, are you like really relaxed right now? We're doing those breathing and you are a relaxed girl.
I am very relaxed. I bought a new couch last week and it's super comfortable. So this is like my hangout spot.
So when you start to labor, you need to go to that couch. All right. So anybody have any questions about that so far?
Mrs. Walker,
Yes.
I have a quick question. Earlier you were saying that when you ask the patient about the birth plan and they say they don't want any pain medication or C-section and anything, when the situation change, do you have to make them sign another consent?
No, that birth plan is just for them.
Okay.
That is what they have worked with their spouse on what they want or what they anticipate their labor is going to be like.
Okay.
So it's theirs. And yes, we will honor them unless there is a situation that I need to, because I remember I was like, I ain't having nothing. I ain't doing this, I'm doing that. And one of the biggest things that I didn't want to stay in the bed when I was with my first baby. I was like, I'm not staying in the bed. And so I told my nurse, I'm not staying in this bed. And at that point, they let me get up. And we'll talk about why they let me get up in a little bit. But, some moms, have what they want, and we can do it if it's within the RAM and everybody's going to be safe.
Okay.
All right. Any other comments or questions? All right, so things that you're going to see, our goal for the childbirth education is to help them cope with pain and massage, and we've already talked about that. Another thing that you're going to see that's really, really common now is the birthing ball. I don't know if those of you that have been into labor and delivery rotation yet, have you seen this birthing ball? It's relaxing, but it also assists, and this is going to make a little bit more sense when we get into what the baby actually does coming down the canal. It'll assist the baby in moving down the canal. Some babies want to stay up with their mamas forever, and they don't want to come down into come to the outside world. They like where they're at. They're all warm. They're all comfortable. They can move like they want to. Nobody's telling them to stop doing this, and nobody's telling them to do all this. They love it in there. And there's some babies that don't want to come out. But this will help. For instance, my grandbaby, she wasn't coming out. She was happy where she was. 12 days late, she wasn't coming. But the birthing ball will help her. And they did that for Ashton and had her turn her positions and put her on that ball. It just helps with getting that pelvic bones. And when we start talking about the pelvic bones, you're going to understand more what I mean about it moving around. Okay. So those are all things that we can do. All right. Now we're going to the 5 factors of labor. You have to understand these 5 P's. This is something that's going to be, well, let me just back up just a second. Boards, this is a specialty area. So boards doesn't really test you a lot on labor and delivery because it is a specialty area. What they test you on is things like, do you know the physiological issues with labor? What makes labor happen? What is all the things working together that helps labor happen? That's what boards wants to know if you know. So the 5 P's is very, very important. The passenger, the passageway, the powers, the position, and the psyche of the patient. So we're going to talk about each one of these. The first one we're going to talk about, and I'm going to have to move y'all over just a little bit. There are excellent pictures in your book. I mean, excellent pictures. I've tried to put a lot of the different pictures in the PowerPoint for you to help you, but I like them in the book. So most everything that I've got them posted up here is also in your book. So you can see them in there better. All right, so let's look at the passage. Of course, everybody knows that we have a bony pelvis area. There is a false, and then there is true. The true pelvis is what we're going to be looking at with labor, okay? Because we need to know that there's an inlet and that there's a cavity and that there's an outlet. So in that true pelvis, it's going to show us a lot of different things that is going to make this labor thing work better. I have to move you guys over here because I can't see my PowerPoint. You are still seeing my PowerPoint, okay, right?
Yes.
Okay, good. All right, so let's look at the 4 different pelvises. I wrote them right there, but I think I'm gonna like this picture better. If you guys have your book right there, if not, you can put this up. You can just look at the screen or you can pull yours on up anyway. So these are our 4 different pelvises that women have. Everybody has a different type of pelvis. The most common and the best one for delivering a baby is this gynecoid. This one right here that I'm pulling. See, I always think, look at that pretty little heart. So that tells me that it is good to deliver this baby. The other one that is good is the anthropoid. And those 2 right there are the best for delivering a baby. Now, does that mean that the other 2, if you have that type of pelvis, that you can't deliver vaginally? Absolutely not. You can deliver vaginally, but I can tell you it's going to be very, very painful. It's going to be more difficult. The baby is going to have a more difficult time actually getting into the inlet and through the outlet. And we can look at the different reasons why. One of the most important ones, if you look down here at the mid pelvis, where I've got here, look at that, the android. Look at that one. If you go to the mid pelvis, look right here where I'm pushing right here, can you see me circling this? What is this right here?
Is that the tailbone?
That is the coccyx.
Coccyx.
Yeah.
Yes, it is. That is the coccyx. The coccyx in the way.
Yeah.
And that's a thick, thick bone.
Mm-hmm.
Gets in the way of that baby coming. It may be able to get down into the inlet of the pelvis and may be able to start coming out, but that pelvic bone is right. I mean, that coccyx bone is right in the way. So the majority of the people, yeah, I can get this out of the way by positioning my patient in different positions. I may have to have her deliver on her side to help pull that coccyx out of the way. But I can tell you that the majority of the patients that have this type of pelvic area break their tailbone or that coccyx area in delivery. And guess what? There's nothing we can do.
So they break it? They break it?
They break it. Absolutely. It breaks.
Wow.
And so you got to think about having a baby and then having a broken tailbone. Think about ambulation. It's going to hurt. And guess what, guys? There's nothing we can do about a broken tailbone. There's no surgery to repair it. There's nothing. It's just going to have to heal on its own. And then can you imagine from having another baby? That mama's going to say, do a C-section because I'm not going through that breaking the tailbone. So in the education when your patients are going for their prenatal checks that they go every week or every month and then they go every week, the physician can tell that they have a different type of pelvis. Can I go in and do a vaginal exam and tell what kind of pelvis they? No, absolutely not. I have no idea. So I had to depend on the physician to tell me what type of pelvis. They can tell me that as the nurse, and I'll say, oh my goodness, we're going to have a difficult labor with this patient. So I know that one of the biggest things that's going to probably happen is I'm going to have to position her a lot while she's in labor because she has this type of pelvis, and it's going to be very, very difficult to get that baby through the canal. Does that make sense?
Yes.
If you look at the gynecoid, look how pretty right here. Where is that tailbone? It is completely out of the way. So that baby has ample ability to move down that canal. That one is so pretty. This is what you want. When you go to the gynecologist next time, ask them what kind of pelvis you have, because if you're going to have a baby, then you're going to know which kind is the best. So any questions about the different types of pelvises that we have and what the ones that are the best and the ones that are not good for delivery? And when I say not good, that mean, do you understand what I mean? If you look at the platho over here, or the plathy, look how this is shaped. You see where here, it is here, where I'm circling.
Yes.
My baby's head is round. And a round head is not going to go through that. So there may be some physicians that look at the patients that have this type of pelvic area and say, your baby's not going to be able to make it through this canal. Is not going to be able to do it. So, but they may let them try. But the majority of the times, what happens when you have these different types of pelvises that are not ideal for vaginal deliveries is the mom labors and labors and labors and labors and labors and labors for hours and hours and hours, and the baby doesn't move through the canal. So it's the baby's way of telling you, I can't come, I've got a round head, it ain't coming through this way. So a lot of mamas that have these types, the android and the plathy, will end up in C-sections. Okay. Any questions about, you've got to know the types of pelvises and what works good and what doesn't work, because the passageway is pelvis bones. That's the only way the babies can get out unless we do a C-section. So he's got to get out that way. Let me get back to where I was. Okay, so now let's talk about that little booger. That little booger that is going to come out, and it's the thegus and it's the passenger. One of the things that is so wonderful about this fetus is that his skull, I keep hearing people going in and out. Is that, I mean, why am I hearing people going out? Can y'all hear that too? It's a little distracting, but anyway. Okay, so one of the things that's really, really good about the passenger is that this baby is head. Now we're just talking head. We're not talking about anything else right now. First of all, let me just ask you, does anybody know what the head coming down first is called?
Crowning.
No.
Is it position?
The position of it.
Okay.
The position of it is called
Cephalic or
cephalic or vertex. Vertex. So when I'm talking about the presenting part, we'll talk about the presentation in just a little bit, is that presenting part has got to be the head, or it needs to be the head. But there are times that heinies try to come first. But we're focusing right now just on the head of this little passenger. His face and the base of his skull are fused and fixed. They're not going to move. Okay, so that skull's already set in stone and it's not moving anywhere. But the vault of the skull has things that are not, has bones that are not fused together yet. It has two frontal bones, has two parietal bones, and the occipital bone are not fused. So what does that tell you, or what does it mean if they're not fused? What can happen with that baby as it's coming through the canal?
The head can mold.
Damage.
The head can damage, absolutely. If they've got to be, the head doesn't, it can be damaged, and we'll talk about that in just a minute. But is this something that's going to help?
Yes.
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 Yes, it's going to help it, because if that pelvic area is smaller than its head, the baby can, the bones can overlay themselves. They can move a little bit to adjust to the passageway. So the passenger doesn't have all these fused bones, because as it comes through the passageway, it can maneuver itself to be pushed through the canal. And so it can overlay that. One of the things that you're going to see a lot, let's say my patient has been really laboring for a long time, and the baby's been down in the canal for a long time. It's just not the cervix is not dilating. So that baby, when it starts to move the bones a little bit, if it's been down there for 8 hours in the same position, you're going to see a lot of molding. Has anybody ever seen a baby be born and it looks like a cone head?
Yeah.
When my mom
Cone
had,
head.
they had to mold my head.
Yeah. And it's like this. It comes up just like a little cone. And that's because that baby the passenger has been in that passageway for a long, long time, trying to make it through that passageway. And that's why that's why they're not fused, so it can adapt to the situation that it's in. Is molding always bad? No, it's not bad. It's just, and what does mama do? Freak out. Because, oh my gosh, my baby's got a cone head. So what are you going to tell her?
That it'll go away after a little bit, you know?
Yes, it will go away after a little bit. So let's think some education things that we need to tell her.
Okay.
We tell her why this molding has happened.
Yes.
Okay, so tell me why this molding has happened.
The molding has happened in order for the baby to pass through the birth canal. So because the bones are not fused, it allows it to adjust to the, whole process of it going through.
Oh my goodness, that was great. See how we're going to educate the patient?
Yes.
We got to educate that patient, because everybody thinks that their baby's going to look like the Gerber baby when they come out.
Right.
Babies don't look like the Gerber baby. I'm sorry. They got a lot of things that's going on. But aren't we thankful that these bones are not fused and that they can make that way through the birth canal?
Yes,
and we have some molding. Molding should repair itself within 24 hours. So we can reassure the mom that this molding should get better in about 24 hours. All right, so next one. So I made this little thing so you can actually see what all happens or what bones are that we have of the skull. You should already know that. But two things that are different from my baby is their fontanelles. Of course, I mean, besides the all right, spit it out, Miss Walker, where the bones can overlap and move and they're not fused, they also have two other very important, you guys have already learned about this, I think, anterior fontanelle and the posterior fontanelle. Have you guys already learned about that with your newborn assessment?
Oh, yeah. Briefly.
You better.
Briefly.
Yes.
Well, I haven't had it yet, so.
Okay. So you hadn't had OB yet, but those of you that have had OB, you should have already done an assessment on that baby and assessed the baby for the anterior fontanelle and for the posterior fontanelle. The anterior fontanelle is right here. Think about the baby's nose being right here. So this is the anterior fontanelle, and it sort of feels like a diamond. And I can bet you $100 State Board of Nursing is going to ask you about that anterior fontanelle and when does it close? And it closes around 18 months. So it took us 9 months to make this baby, and his bones were not fused together in the top of his skull. So it's going to take about 18 months to get all that fusion started and completed. So that anterior fontanelle takes about 18 months. The posterior fontanelle looks like a triangle, and it's going to close around 8 to 12 months. So once that starts closing up, now a lot of people say, oh my gosh, have you ever heard the anterior fontanelle called the soft spot?
Yes.
Yes. Do you think it's soft?
Probably not.
Nope. It's tough as all get out.
Okay.
Tough as all get out. Have y'all ever heard that term, get out? So it is very, very tough. Not that I want to drop something on my baby's anterior fontanelle, but it's very, very, very tough because look what all it's been through. It just came through a vaginal area. And everything is very, very thick. That skin is very thick. But tell me about the anterior and posterior fontanelle. What kind of information, particularly in the anterior, can I tell about a baby at the very beginning or until it closes?
In cranial pressure?
Increase in your cranial pressure or?
Hydration status.
Hydration. Who said that? High five. So who said it? Are y'all not taking credit for it?
I did. Sorry, I couldn't get off mute.
Okay, go girl. So that anterior fontanelle can tell us about their fluid. Yeah. So what's it going to look like if they're dehydrated?
Sunken.
It's going to be sunken. Absolutely. So what if they have increased intracranial pressure? What's it going to look like?
Bulging.
It's going to be bulging. Oh, yay. Yay. So I didn't teach y'all anything. Y'all already knew that, right? All right. So you know how important the skull is and the anterior and the posterior fontanelle. And you know when it closes. All right. Are we at a point where you want me to take a break? I have 10:56. You want to take a 15-minute break?
Okay.
Okay. So I have 10:56 and we will come back at what time? It's 10:56 in 15 minutes. I can't do that. Let's say 14 minutes after. All right. All right. I didn't make it as far as I wanted to. All right. I'm going to mute myself because I'm going to talk to my mother.
Yeah.
Yeah. Yes.
Yes. All right. I need to make a correction. If you look on this PowerPoint right here, it says posterior closes around 8 to 12 months. It's supposed to be 8 to 12 weeks. And it is on page 324 in the last paragraph. So I made a mistake there. I got happy fingers and was stuck on months.
Wait, say that one more time. Sorry, I missed that.
So posterior on this slide right here where it says posterior triangle change closes at 8 to 12 months is 8 to 12 weeks. And it's on page 320, what did I say? 324.
Just for the posterior or
Just for
both
the
of them?
posterior, yes.
Okay, thank you.
It's 18 months for anterior and it's weeks for posterior. And thank you so much. I think that was Maya that told me about that. I've been working on this slide in this presentation for a long time, and I guess I just didn't catch it, but I appreciate you letting me know. All right, so if we're ready to move on, we'll go to, I just can't find a place to move y'all on here. All right, another issue. I cannot see y'all. This is, okay, now I think I'm good. All right, so another thing that we look at with the fetus inside a utero is the fetal attitude and the fetal lie. So these are another part of the fetus that is going to help us in understanding what's going on with the baby and how close are we actually going to labor. The attitude is, have you ever heard anybody say, oh, he was in the fetal position or the fetal, it's really talking about the fetal attitude. When you've got the flexion of the head and the flexion of the arms on the chest and the flexion of the knees coming up to the abdomen. This is generally the position that the position that the baby stays in throughout utero. He moves a lot, they move a lot, but it's generally when you talk about their attitude, is they're in that fetal position. So that is just another way to describe what's going on with our baby. And that's the fetal attitude. The fetal lie, I either want my baby to be longitudinal or transverse. Now, during the pregnancy, the baby sometimes will be transverse. And when I mean transverse, it's like this way. Like here's the abdomen and the baby's laying like this, like the head's over here and the butt's over here. I can't even see myself on here, so I don't even know if y'all can see me. Can y'all see me? Okay, so yeah. It's laying this way. We want the baby to lay up and down. The lie is the relationship of the baby's spine to the mama's spine. Okay, now we'll talk a little bit about, and later on when we get into the actual stages, is when that baby is got his spine against mama's spine. Mother is going, and we call that baby's posterior. Okay, so what happens is, and this is the way that we can tell if the baby's spine is directly laying on mama's spine, is if mamas, while they're in labor, get no relief in between their contractions. Okay, it's called posterior labor. So they're having contractions, but they're still in between the time of contractions, they're still complaining of some back pain. And that's the reason why the baby is on their spine. So tell me some interventions that you may want to do for a mom that is contracting every 2 to 3 minutes and not getting any relaxation or any relief in between the contractions. What would be something that you would want to do for her?
Turn on her left side.
You could turn her on her left side.
My mom had back labor.
I'm sorry, keep going.
Counter pressure.
I didn't hear that.
Counter pressure, like rubbing her back really hard.
Absolutely. And moms will tell you it hurts right here. They'll tell you exactly where it hurts. And you can feel like you're actually hurting the mother, but you can take your fist and just put that counter pressure on there. Sometimes I recommend a tennis ball. And if moms have been through Lamaze or Bradley, they'll tell them about a tennis ball too, just in case they have that baby that is got that position straight on mom's back. Another position would be the knee chest. Or a lot of times what I do is not necessarily the knee chest, but I put the head of the bed up and have the mom lean over. So the baby is going off of her spine. So gravity's making the baby come down a little bit, and it gives her a little bit of relief for that, for her back. Okay, so back labor is very hard. I'm sure you probably heard the term back labor before. Professionally, it means that the baby is posterior and that his spine is directly on mama's spine, and mom doesn't get any relief between the contractions. She's still having a lot of pain between the contractions. Now, transverse, that position is not good. If we can't get that baby to move from the transverse position, mother will have to have a C-section. You cannot deliver this baby with a transverse lie. This baby is this way. In other words, that spine's going to try, or the shoulder's going to try to come out first, and that is not what we want. We want it to be vertex. We want to be head first. So if we can't get this baby to turn, then your mom is going to have a C-section. Trying to move you guys again. All right, any questions about the attitude and the lie? All right, presentation. Here's another part of those P's. Either when we talk about presentation, we talk about the first thing or the first body part of the baby that comes into the pelvic inlet. Remember, we talked about the pelvis just a little bit ago. So what is the presenting part? Is it the head, which is vertex? You're going to hear that term vertex more than you're going to hear cephalic. V-E-R-T-E-X. I think that's how you spell it. Vertex. V-E-R-T-E-X. Yes. Vertex. V-E-R-T-E-X. You're going to hear breech. What does breech mean?
Feet first.
High knee first.
Okay.
High knee first or feet first. Okay. Wrong direction. And then you can have a shoulder presentation. So this picture is also in your book. So you can see the frank breech is when that baby's high knee is right there. Have I ever told you about the time I was working in labor and delivery? And I don't think I've told you, I might have told you guys this. Stop me if I have. I was working nights and I went to check my patient and I did a vaginal exam, and I could tell that the patient was about 3, maybe 4 centimeters, about 75% of face, and that'll make sense in a little bit. But there was something there I couldn't figure out what I was feeling. And I kept poking and I kept poking and I kept poking, and I thought, what is this? So I went and got the other nurse. And
oh yeah, you told us this.
I told you that? Okay, it was a scrotum. Make a long story short. So can you see on this Frank? I won't tell you more then. Frank breech, if this was a boy, can you see where his scrotum would be right there? So, and I think I told you in that story, if you have a mom that's a first time mom that's getting ready to deliver, she has not delivered yet. If you have any type of breech presentation, shoulder presentation, footland presentation, you are going to have a C-section first, right then. Moms they will not let people deliver this. Can anybody tell me why?
So, Miss Walker, in our clinicals last week, a mom, it was her second baby, but the doctor let her deliver a frank breech vaginally.
Okay, because it was her second.
Mm-hmm.
Okay, second baby.
He
So
said it was also because the baby was so tiny. He was only 5.5 pounds, so she was able to deliver it vaginally.
good, good. And that's the best thing, because we don't want moms to have to go to surgery if they don't have to. But let's say we've got them, and I think that's great that you actually got to see a breech baby be born. But the biggest thing, let's think, why would we not want somebody to have the first time have a breech baby?
Well, does it have to do with because they're breech now, they have a higher risk of birth injury?
Birth injury and what else?
Getting stuck.
They're
Getting stuck.
losing oxygen, and then now we have a bigger problem because we may run the risk of now your baby will be like have cerebral palsy, because we know with each contraction the baby's losing that much more oxygen, and now they're in the wrong position, and we run the risk of all of that, the combination of all of that stuff.
What about fetal death?
That too.
That too. All right, so let's think through this. Why would somebody not want them to have breech? Because what is the biggest part of that baby?
The head.
The head. So let's say we get the feet out.
And now you can't get the head.
We get the
Can't get
torso
cord
out.
The cord.
Yeah, and the cord can come out too. So if we get the feet out and we get the torso out and then we get the shoulders out, but we got the head to go, right?
Yeah.
Is that the biggest part? What if this mom has a pelvic area that cannot open up enough for her to deliver the biggest part of the baby? Are we going to take that chance? No. Now, that's what they used to do in a long time ago when they were out working the fields and that they had the babies and they were breached. And what would happen is that we couldn't get the baby out. So whoever was there to help, or the mom, whatever, they ended up breaking the baby's neck and the baby died because they could not get the baby out that way. So right now, or for the mom and the baby's sake, if anybody has the first baby, and I'm talking the first one, and it's breached, they're going to do a C-section. Now, with the second pregnancy and second delivery, what we look at is how big was your baby. Like my first baby was 6'15". So I have a cervix and a pelvic area that is proven to be able to deliver a 6-pound, 15-ounce baby. So I've got the proof. So with this mom that you guys were talking about seeing that breech the other day, that mama's baby, do you happen to know what the birth weight of the first baby was?
I think she said the first baby was 6 pounds, 8 ounces or something like that.
Okay. So her pelvic area is proven to deliver a 6-pound, 8-ounce baby. This second baby, breech, weighed what, 5 pounds? So would you let the mom take the chance of delivering? Because it's already proven that she can have a 6-pound, 8-ounce baby. We got to be very precise on, do we know the weight of the baby? Does that make sense? Do you follow me when I'm saying that it's proven that this is your first pregnancy and you've never delivered a baby before, you have no proof that your pelvic area can deliver a baby. You have no proof because you have no previous history of delivering that baby. Does that make sense? So they're not.
Miss Walker, you're just saying like there's enough space for that baby to come out.
Absolutely. Absolutely. So it's there that pelvis of that particular patient, just this patient right here, not everybody else, just this patient, individual patient, she has proven that she can deliver. I proved I could deliver a 6 pound, 15 ounce baby. So I know that there's enough room there to at least get a 16 pound, 15 ounce baby through there. Now, if they will go in and say, oh my gosh, this baby weighs 9 pounds, do you think they're going to let that baby deliver vaginally if it's breached, the second one?
No.
No, not going to, because that particular patient has only been able to deliver a 6 pound baby, 8 ounce baby. And this baby weighs 9 pounds. There's no proof that this patient can get that 9 pound out. So they will probably do a C-section. Does that make sense? Are y'all following me?
Yes.
Okay, good.
Yes, ma'am.
All right, perfect.
And that's only for a breech birth?
Yes, that's for breech or shoulder or any other presentation than the vertex. We want it to be vertex because the vertex, and when we say that they're proven, the vertex is always the biggest part of the body. Once we get the head out and we get the shoulders out, then everything else just flies right behind it. So that's the smallest part. The feet are the smallest part of coming out of the vagina. So we've got to make sure that we have enough proof to get that baby out, because that baby's going to damage. It could break its neck if we can't get it out because they don't have enough room in their pelvic area. So that's why it's important to understand the pathophysiology of the pelvic area and knowing if we have enough room to get this baby out.
Miss Walker, quick question.
Yes. Yeah.
For A, B, and C, like I can imagine the baby coming out, but for D, like the shoulder presentation, I just cannot. Like, does the baby have to be turned at that point to come out?
This baby is also transverse.
Mm-hmm. Yeah,
that's a picture of transverse.
Right.
They'll let this mama deliver.
Okay, that's what I was like. I don't even understand how that would even happen because it's transverse.
No way whatsoever. Now, you could try to move this baby, but you're going to put more damage on the mom and the baby than you are doing a C-section. This is definitely going to, this transverse, C-section all the way. No way getting out. Good question. All right, so other things that we need to look at when we're talking about the passageway and talk about things is engagement and station. When I talk about engagement, I mean that the baby's head or the presenting part is actually engaged into the pelvic area. So if I look back here, when I mean engage, is it, well, not that one, I don't want that one. Let me go to this one. So these are two terms that I need you to understand. Engagement, meaning that the baby has got his presenting part down in to the pelvic area and it ain't going nowhere. So it is good and locked in there. There are times that you can do, a nurse can do a vaginal exam and they can push on the baby's head and you can feel it floating around. Does anybody know what that term is? Y'all should have talked about that in Intrapartum.
That's the Ptolemate.
I'm sorry. Say it again.
If I'm pronouncing it right. Is that
the allotment? Absolutely. So if you can do a vaginal and you can push on the baby's head and it goes floating up in there, it's blottable. It's not engaged. So when I do a vaginal exam and I push on the baby's head and he doesn't go anywhere, he's engaged. So that means that he is in position. He is ready to start this birth process. So engagement is very important. Have you ever, well, I won't do that yet. Okay. So that's one. Engagement is one. Head down, ready to go. We're going to get this thing going. Station is another term that we use when we're assessing a mom in labor. One of the things that you're going to hear, or three of the things that you're going to hear that nurse in labor say all the time, is how much the patient's dilated, how much they're effaced, and what station are they at. The goal of a station is to get the baby out. So when you do a vaginal exam, and I know you're not going to as a nurse, as a student, on the sides of each pelvic area, when you go in to do the vaginal exam, there are two little knobs that stick out like this that are called the ischial spines. So when I go into the vaginal area, I'm doing an exam, in the pelvic bone, those ischial spines are on each side. So when I stick my finger in there, I'm feeling for those ischial spines. And the station is the relationship of where the baby's presenting part is in relationship to the ischial spines. Do you want me to say that again?
Yes.
Yes.
The station of the baby is defined as the presenting part, where the presenting part is in relationship to the ischial spines. This is a very difficult thing for nurses to assess. So if I do a vaginal exam and I go in and the first thing I feel for is those two little knobs on the side, and my finger goes past the knobs. So if it goes past the knobs and the head is way up here and the knob is right here, that baby is not engaged and it has a negative station. Okay, so if I can take my finger in here and I found this, can y'all see me, the ischial spines, and then I take my finger past that, that is how I assess to see, here's the ischial spines and that baby's head's at the end of my finger. It's not engaged and it is a negative station. So am I concerned about that baby getting ready to be born right now?
Miss Walker?
Yes.
Can you explain that again? You lost me.
I'm sorry, can I explain it again?
Yeah.
Okay. This is a very difficult concept to understand. If you remember that the presenting part is the head or the vertex, what I'm trying to figure out is how close is this baby to being born? Okay, that's what the goal of this is. So when I go in to do the vaginal exam, there is two little knobs on the side called ischial spines of the pelvic. It's on the pelvic. I find those first. Then I find where the presenting part is. If here's the ischial spines and I go in and I can't feel the baby's head or the presenting part, it's at the end of my finger, then that baby is not engaged and it's not gonna be born anytime soon. So it's a negative station. I'm trying to think of another way to say this. This is very different. This little thing right here looks, that's the best way I can describe it to you.
So if you can feel the head, that means that it's about to be born, like it's close to being born.
Okay, if I can feel the head and I'm gonna feel where the ischial spines is, if the baby's head is even with the ischial spines, say it's right there. So here's my finger, I'm going in, here's the ischial spine, and the baby's head's right there. That is a 0 station and he is engaged. So if I do an exam and here's the ischial spines and my finger's way back here, then that is a plus sign or a +1 or a +2. When the baby's crowning, that is a +3. When the baby's coming out.
Miss Walker, does that have anything to do with the dilation and the centimeters, or is that something separate?
This is something separate.
Okay.
So
Totally different from, this is totally different from dilatation and effacement.
okay, I have a question.
Yes.
So if this makes sense, the further your finger can go in, the more negative it is.
I was trying to turn the volume up, sorry, so I can hear y'all. So go ahead and say that again.
So the further your finger can go in, the more negative it is?
Absolutely. But you're trying to see the relationship of where is it to the ischial spines. Let's say that I go in and I can't even feel, there's been times that I've did a vaginal exam, I found my ischial spines and my finger cannot feel where that baby is. So that baby is still floating around in there. He's not engaged into the pelvic area. And am I really worried about the birth getting ready to happen right now? Absolutely not. If I go into the vaginal area and I feel a head as soon as I go in, then yes, the progression is getting ready to happen and we're getting ready to have a baby. Okay, does that make sense?
Yes.
Does anybody have any more questions?
You said +3 is crowning, right?
Yeah, +3. And if you look at the next one, then this is the big joke on OB. +4 is on the floor. Okay, so if this baby is a +4 station, he is coming out. When I say about crowning, I don't know if you've talked about crowning before, that's when the baby's head's actually, the vagina is actually going to open up and you're going to see a portion of their head. That is a +3, and +4 means that it's coming out. Okay. It was, and then like the nurse is saying, I told you 15 minutes ago, she was at +3. So +4 is on the floor. And we cannot let that happen. Okay, so are you understanding the station?
Yes.
Yes, ma'am.
I'm gonna let you process that a little bit longer, and then when we come to class on Monday, if you have any more questions or if you want to email me, I will tell you that my office hours this afternoon are going to be cut short. I'm picking out tile for my new bathroom, so I will not be here. Okay, so station is something that you're going to hear. If you hadn't already been to labor and delivery, you're going to hear this more and more and more. It gives me an assessment. Remember, we've got to assess to see. So when you're thinking, if you are going and listening to the nurse and she says -2, do you think that delivery is getting ready to happen?
No.
No, absolutely not. But if she tells you she's at a +2, do you think it's not going to happen right now, but you think we're getting closer?
Yeah, we're getting closer.
We're getting closer. So it's all about the presenting part and where it is to coming out. How close are we? Because this is set. Do you think the nurse's assessments are going to be different from a patient who has a negative station or in a positive station? You think the nursing interventions are going to be different?
Yes.
Yeah, because at negative, am I in a hurry?
No.
No. A positive, I need to be getting my stuff together, right?
Yes.
People can go from -4 to +4 in 15 minutes.
Mm-hmm.
Okay, so you've always got to be aware of what's going on and where that station is. All right, this is hard. The station was a little bit hard. The other stuff is pretty much, you know, it is what it is. I think the pelvics, learning the different types of pelvics is a little hard, but this is hard. This position is hard to wrap your head around. Okay, I'm just telling you right up front. But for some reason, State Board of Nursing wants you to understand this. Okay, so the position of the fetus, where is it? It is defined in using 3 different letter system. The first one is very easy. Is it on the right side or the left side? The presenting part, okay? We're just talking about the head, okay? Now you understand that there's other presenting parts, but right now we are focusing on the head, okay? The occipital, well, I'll show you. All right, so right or left, that is the right or the left of the mother. Okay, so it's the mother's right or left. The next letter is either an O for the occiput, S is for the sacrum. You know what the sacrum is? The butt. M is for the chin. The mentum is our chin. And SC is for the scapula, which is the shoulder area. Okay, so you're going to figure out when you look at this, is the baby on the right, the occiput on the right side or the left side of the mother's pelvic? Okay. The other thing, remember we talked just a little bit ago about the anterior or the posterior? Anterior or the posterior is where the baby's spine is on the mama's spine. That is a posterior. The transverse is very easy because you know that transverse goes this way. Okay. All right. So it's a 3-letter system. All right. Let's go to here and I'm going to show you how to figure out this one up here that I'm circling. Okay. When you look at that pelvis, find the occiput, which is right here, and tell me which side is on the mother's. Is it the right or the left? And if you have to turn yourself around, remember it's opposite when you look at that, right? Right?
Right.
You're not talking to me. So when you look at this picture, your right side is this side is her right side. So flip it. Okay. So do you see where in this, oh, I didn't mean to do that. Oh shoot, what'd I do? Okay. Do you see where the spine is? This is to the front. Okay. So it is anterior. So this is the right side. The occiput is the presenting part right here. You see it right there. And then the is anterior. You want to see the difference in the ROA and the ROP. Look all the way to the side, to the right side right here. Is it still, here's the occiput. Is it on the right or the left side? Right there it is. In here. It's on the right side. Okay, where is that baby's back?
Posterior.
It's posterior, but it's the right side of that mama, the occiput, is right here. That's the presenting part. And then the back is against the back. That is posterior.
I'm still a little lost.
Huh?
I'm a little lost.
I know this is very hard. This is hard. And just like I said at the very beginning, it's hard to do this. So when you're looking, I'm sorry, I got a call. So is anybody having, you first thing you need to find is the presenting part. What is coming out first? Okay, all of these. Okay, let's look at this one right here. Okay, I have to find the presenting part first. Is it the occipital? Is it the chin? Is it the scapula? That's what I have to find first. Because once I find that presenting part, then I can then know where is it facing, the right side or the left side. Okay, and then I can figure out where the spine is. Is it anterior or posterior? Okay, so I'm looking at this one right here. What is the presenting part?
The chin.
The chin. You see it right there? Do you see this chin right here? And what side of the mama's pelvis is it on?
The right side.
The right side. And where is that back?
The right.
Anterior.
It's anterior. So that is RMA. The most common ones that you're going to see is ROA and LOA. Okay, so you're looking, find what is presenting. Look at this one up here, ROT. So do you see the occipital? It's right here. And it's facing more to what? He's actually, this might make sense. The baby is facing the left side, but the occipital is on the right side. See if that'll make better sense. It's like, which way are they turned? Are they turned to the left or are they turned to the right? Because you can look at look at that ROA and the LOA. Look where that baby's facing. So if he's facing the left side, his occipital is going to be on the right side. Because your occipital is right here. So I'm turned this way, but here's my occipital. And that is what I'm trying to figure out where it is. Do you see that baby looking to the right, to the left side? This baby right here is what I'm looking at. Look at that baby. Is he looking to the left side of the pelvic area? You see him? But his occipital is on the right side of the mama. Is that a better explanation?
Yes.
And then look at the LOA. Where is this baby looking at? I'm looking at this right here. Where is he looking?
The right.
He's looking at the right. So his occipital is where? I mean, his occipital is where?
The left.
On the left side. And where is his spine?
Anterior.
Anterior. All right, you want to see a posterior one? Look over here. Which way is this baby looking?
Left.
This baby right here. Which way is he looking?
To the right.
He's looking to the right, isn't he? So that would be the occipital would be on the mama's what side?
Left.
Left.
The left side. Okay. So is the presenting part the occipital? Yes. The head, the vertex. So it's the left side of the mama's pelvic area. It then is the occipital that's there right here. And then look where his spine is. Here's his little legs. So where's his spine?
It's posterior.
Posterior.
So it's up against mama's spine. So this information is going to tell, if I've got somebody that's ROP or LOP, then I know as a nurse, my interventions are going to have to be focused on helping her deal with what kind of labor?
Back labor?
Back
yeah.
labor. So that's how I use my information to know with this position of this baby, if I have someone that is ROP or LOP, I know through this assessment that she's going to have back labor. So I'm going to plan my interventions to assist her in helping relieve that back labor. Does that make sense? Is there a way that I can explain it better that you understand how to figure out, if you're given a picture like this, do you think you're going to be able to tell what position they're in?
Mm-hmm.
So if the spine is posterior, then you know you're going to have back labor.
Absolutely.
Ms.
Mom,
Walker,
yes.
I have a question. So
Mhm.
with the RMA, it's anterior, but it looks like the baby's spine is facing towards the mother's spine. So in my head, I would think that would be posterior.
Okay, on which one?
RMA.
Okay. So I've got my chin coming here.
Yeah.
I have to start from the very beginning.
Okay.
My chin is coming here, and my baby is actually looking to the right of the pelvic. He's looking to the right. Okay, so my back, that does look a little posterior on it.
Yeah, that's why I was just a little bit confused. I understand all the other ones. That one just kind of confused me a little bit.
Yeah, that was a little difficult because even on the posterior one, you can't really tell where that spine is. I can tell you, right? I mean, not that I'm going to teach the test, but I don't like to use things that you don't see much.
Okay.
I want to know that you understand these right here.
Yeah, just kind of like the basic ones.
Yeah, the chin, you just don't see that.
Okay, and when it is on the test, are you just going to like give us a picture, or is it going to be more of an explanation?
Nah, I don't know about that.
Okay, all right.
But I'm going to tell you, I want you to understand the things that you see the most recent. The biggest thing that I want you to get out of here is when we're talking about having a position, is that if you see that the patient is having a posterior position, that you understand that different interventions are going to have to happen.
Okay.
Okay. I want you to understand that, but you also need to know, I mean, and I do not teach the test. I'm not teaching to the test, but I can tell you every question, everything that I've reviewed from Board of Nursing, these top 6 are the ones that you need to be able to identify. This chin, that's a specialty. That's a specialty position.
Miss Walker.
Yes.
Just so I'm clear, so for like the anterior and posterior, it's more so like where the spine is, and when you're talking about like left and right, it's more so like how much the baby is on one side versus the other.
Yes.
Right. So it's not so much of like how they're facing, because like the ROA, he's facing the left, but it's more so because the body's on the right, right?
Yes.
Okay,
yes.
gotcha.
I mean, everybody learns how to figure out this differently. I have to see which way they're looking. Yes. So I wish there was a way that I could really explain this to you where you would get it. But this was one of the hardest things for me to learn when I was in nursing school. I could not get it. So after you digest it and you're still having trouble, then let me know. But you know that you've got to know the 3 letter system. You have to know what each one stands for, correct? You would know that, right? And then that's how you figure out the positions. All right. Now it's 12 o'clock. Do you want to take another break or do you want to keep going?
Let's keep going. We have a lot to go.
Okay. Are we doing good? Are we hanging in there?
Yes,
I know.
ma'am.
I feel like this is a lot of information, but it's basically anatomy and physiology and knowing what all labor does. All right. I only have 163 sides, so that's not really bad compared to what y'all usually have, right? And we have how many more days? 3 more days to do 3 hours? I think I
We
could.
have 2 more days, I think.
I thought we had 3.
Because we missed today.
Oh, shoot.
We do have 3, I think. Well, yeah, actually it is 2. Oh, well.
Okay, so we have today, and then we have next Monday, the 23rd, and then we have
Monday, I think, again.
Monday, the 30th. And then, yes, we'll get through it. We'll get through it. All right, so let's go to the forces. This is the biggest thing that our patient's going to be hurting, okay? These are the contractions. There are 2 different kinds of contractions. You've got to understand that the primary forces, that type of contraction, the job of the primary contractions are to cause effacement and dilatation. That's their job. So the contractions are going to be different when the patient progresses and is ready to push. After she has completely dilated and completely effaced, then the type of contractions change to more of a push contraction. And most women will tell you, and those of you that had babies before, that is a relievable feeling. Mm-hmm. Like it hurt, but it's almost the contractions are going to be like pushing down. That part didn't hurt. Most people think, oh my gosh, I can push this baby out. But those contractions don't hurt as bad. They hurt, but it's more of a push with it. So the goal of the first contractions is to get us dilated. And what do we mean by dilatation? I'm going to show you these pictures right here. This is the actual cervix. Can you see how it is so long and closed? Like right here should be the opening. This is where the dilatation occurs. With this, there's a major job of the cervix. The cervix being, and I use this term a lot, long, thick, and closed. That is what I want to hear about this cervix before the babies do. I want to see that this is long, thick, and closed. Do you see what I mean by the opening here? This is the dilatation, right where I'm pushing right here. There is no way if I went to stick my finger right into that cervix, can I get my finger in there at all? I can't, because it's completely closed. This is the barrier from the outside world. This is what keeps my baby safe inside the utero until they're due. The bag of waters keeps them, and there's also a mucus plug. When you're pregnant, this whole area right here is full of mucus. A thick thing that looks like snot is full of that. That's the barrier from the outside world. This is what keeps my baby safe. So when a patient is long, thick, and closed, if you hear a doctor say that, there's no way that he can get a finger in here. And that all of this is the cervix right here, and it's not thin. Do you see how thick it is? Mm-hmm. It's about a cervix on a normal non-pregnant woman is about 3 to 4 centimeters. So it's very, very thick. So that's telling me that this mama right here ain't doing nothing. There's no effacement, there's no dilatation, and that little baby's head's just resting right there. Now he's getting ready, but not quite time. So if you look at this picture right here, can you see the opening right here? If you were to stick your finger in there, could you get a finger in there?
Yes.
Yes, you can. So she's probably about 1 to 2 centimeters dilated, because the dilatation is the opening. That's how big it's going to, and it's going to be measured from 1 centimeter to 10 centimeters. Okay, so that's how big. I want it to be 10 centimeters. If you look at the difference, I'm moving that. Look how thick this is, but look how thin this is getting. Can you tell the difference with effacement? This patient right here is almost thinned out. About 50% of that cervix is getting out of the way. When the patient is laboring, you have to go through effacement before you can get them dilated to 10 centimeters. So you're going to have to efface before you dilate. So this lady right here has made a lot of progress as she's getting ready to progress through labor. She's may not be but 2 centimeters, but look at all the work she's done. Can you tell the difference in the thickness there and the thinness here? Can you see that?
Yes.
Tracy, you're the only one that answers me.
I'm answering you unmuted, just know.
Okay. I know Ms. Fink said something about telling y'all to be quiet during question, and I sent her an email right after. I said, I don't want my students quiet. I want them to talk to me, because I need them to talk to me to know they're understanding it.
Yes.
All right, good. All right, so now let's look. Look at this. Where in the world is that cervix? It has moved completely of the way. That mom is completely dilated, and her cervix has moved, is all the way gone, is out of the way. So that means that there is room for that baby's head to come through now.
Is that when you say like 100% effaced and dilated at 10?
Yes, that is 100% effaced and 10 centimeters dilated. Okay, so when you're listening to the nurses when you're going to OB and they say my patient is 5 centimeters, that means that they're halfway there. And the dilatation, the effacement is in percentage. So 100% means that it's thin as can be. It's like paper. If they're 50%, that means they're only halfway thinned out. Now the way I measured effacement when I was a labor and delivery nurse, it was either 25, 50, 75, or 100. There's some nurses that'll go in, they're 67.5% effaced. How they do that, I have no idea. I make it easy on myself. Is it 25, 50, 75, or 100%? But what I'm looking for as my patient progresses, and I'm teaching my patient the goal of what we want to meet right now to get this baby delivered, is I'm looking for 10 centimeters to be of dilatation. So when I say to you, you're 6 centimeters, you know you only have 4 more. That's educating your patient. Effacement, if I say you're 50% effaced, then you've got 50 more percent to go. The station is the other thing. If I say we're at a -1, we know we got some work to do, right? If we're at a +2, then it's coming. And we are getting ready to have a baby. Okay. So that is what you're going to see and what you will assess with a patient. Can you see where, when you're having a labor pain, can you see where the data that you're gathering through those 3 different things are going to give you information to base your interventions. Can you see that yet?
Yes.
Thank you. Somebody else answer me. So that is, you know, when you go and assess a patient on the med surg, you're listening to heart, you're listening to lungs, you're hitting this, that, and the other. With a laboring patient, that's the three most important, or one of the three most important things that I want to know to base my interventions on. Okay, so I've got the dilatation, the effacement, and the station. Are you all clear on those three particular things and how you assess those?
Yes.
Yeah.
Okay, I want to make sure you understand. All right, so here we go, contractions. Even though we've already had some contractions this morning, we're going to talk about what we are assessing with the contractions. I want to say it, well, I'm not going to say that yet. All right, so I'm going to look at this because I like this better because I'm a very visual person. So there are certain things that you're going to assess for when you are assessing contractions. Now, how we get these contractions, or how we get the dilatation and the effacement and the station, is from the primary forces. And this is what we're seeing right now. This is the primary force of this contraction. So we're looking at the increment, the acme, and the decrement. So if you look right here, this is when we started our contraction a while ago. And how it goes up. It's almost like when you have medication that you're looking at, and you're looking at the short life of it, or you're looking at the duration of it. How long does it last? When does the peak of the medication? Just almost like insulin. So when the contractions start, you'll see that it'll come up. And then at the very, very top of it, that's as strong as it's going to be. Then the contraction will start going down a little bit. One of the most important things that you need to assess when you are looking at the contraction is this right here. You see where I'm looking, I'm circling right here? This is called resting tone. You have to assess. And I'm not saying look at the monitor. When you assess contractions of a patient that is in labor, it is vital that you use this right here. Everybody see what that is? It's called a hand. It's a hand. And you have got to make sure that you lay hands on that patient's fundus. Do you know where the fundus is?
Yes. Top of the uterus.
Okay, the fundus is the top of the uterus. Now, you're in postpartum, you've been in postpartum, the uterus was way down. With pregnant mama, it's way up here. It's the top. That's the hardest part of the contraction. That is where you take this hand and you feel on that fundus and make sure that that uterus is totally relaxed and totally resting in between the contractions. You have to have resting tone or resting time between these contractions. That is vital. And we'll talk more about that later, but I'm telling you, and you don't just look at the monitor and say, oh, it looks like that they're having some relaxation between that contraction. You take your hand and you lay it on there and make sure that that contraction or that uterus is completely resting. Okay. All right. That's one thing that you're going to assess for. When we're looking at contractions, we want to look at the frequency. The frequency is the beginning of one contraction to the beginning of the next contraction. So if I started this contraction at 12:15, that's when I started my contraction. And I had my contraction and it lasted 45 seconds. And then at 12:19, I started another contraction. What is the frequency of that contraction?
Is it every 4 minutes?
It's 4 minutes. Every 4 minutes. Right now, I mean, I just did 2, but it's the beginning of one contraction to the beginning of the other one. That's telling me how frequent is this patient having contractions. That is another bit, that is a very vital information. And once we get into the different stages, you're going to see how that information is going to help us assess where my patient is in the labor process. So frequency, resting tone and frequency is what 2 things that we've got to assess. Duration. Remember how we started that contraction and we did it for a whole minute? So when the contraction starts, you hit the timer and you keep that timer on until that patient is finished the contraction and that her uterus is resting. Usually contractions can be anywhere from 20 to 30 seconds to 60 to 90 seconds long. Let me just say this, and we're going to talk about this more later, but 90 seconds is too long. Okay, we need to have these patients having contraction that do not last 90 seconds. The book says 60 to 90 seconds, but 90 above, I'm concerned. Okay, and we'll discuss what we would do about that later. So what you need to do the resting tone, the frequency, and the duration. The other thing is intensity. Intensity. You're like, oh, Ms. Walker, how in the world do I tell if somebody's really, really hurting or the intensity of this contraction?
Is it how tall like the wave of the contraction is on the monitor?
Yes, you can see how this right here with the monitor that you're watching, you want to make sure that you have it zeroed in. See where it says 0 here? And you can, on the monitor when you hook the patient up, you're going to make this be 0 when nothing happens, okay? And then you can see how the strength of this contraction is going up to 50. That's going to tell you one way that this is strong, okay? We got to have the strong contractions to make the dilatation and the effacement happen. If they're not having strong contractions, there's no way they can dilate and there's no way that they can efface, okay? But let me just tell you, that is a monitor. I need you to take your hand and assess that fundus. That is the true way of assessing the intensity of a contraction. Okay? Is somebody chatting with me? Because I'm having something. I'm not answering if you are. Okay, so you take your hand. I'm going to give you just a brief way for you to remember about intensity of a contraction or assess the contraction. I want everybody, I made you have a uterus today. So now we're going to get your finger and I want you to touch your nose. How's that feel? Let's pretend like that was the fundus. When I push that, does that feel like a real strong contraction? Real mushy. Do you think that contraction is really, really strong?
No.
No.
No. So if you take your hand and you're putting it on your patient's fundus, and you're feeling here, and that's exactly what this felt. Do you think that she's having contractions? I mean, having strong contractions. Those contractions are pretty mild. Okay. So now I go in and she's progressing a little bit more, and I want you to touch her chin. Can you feel that it's gotten harder than your? Is that a little harder?
Yes.
So I think that contraction might be a little moderate. If that fundus is feeling like my chin is, then that contraction is definitely getting stronger than it was on my nose, isn't it? Right? Right? All right, so that's mild, moderate, and where do you think strong is?
Your forehead.
Your forehead. So feel the difference in that. Can you feel the difference? Are y'all chatting over here on me? I can't see. Are y'all laughing at me?
No, Osmond's being funny in the chat. He said now he has a fundus.
Yes, you do. You've had a uterus and you got a fundus. You are right today, baby. See, all these things that we learn in Crazy Miss Walker's class. But we're having fun and y'all are learning. I hope. Cross my fingers. All right, so do you see mild, moderate, and strong? Can you feel the difference? Can you?
Yeah. Yes.
Think that if you went to assess your patient now that was in labor and you laid their hand on, would you be able to tell if the intensity of that contraction, what that intensity?
Yes.
An idea, wouldn't you? Absolutely. So I'm not nursing that monitor. I'm not nursing the monitor. I'm feeling my patient. I'm making sure that I am knowing what I'm assessing. So what you need to know about contractions are, you need to know the duration, the frequency, and the intensity. So, and that make sure that you have a resting tone or a resting time in between those contractions. Is that going to help you, your assessment, help you figure out how your patient is progressing through labor? Absolutely. Our dilatation, our effacement, our station, all data that we're gathering through our assessment to base our interventions to plan our care for our patient. The intensity, the duration, and the frequency is going to tell us more information because we're gathering all this data through our assessment to make sure that this patient, I'm having the correct interventions for this patient. I just put another little funny thing up there for you to help you remember. You're going to have to know the intensity, duration, and frequency and how you monitor that. Okay. Any questions about that so far? Y'all good?
Yeah.
Okay. All right. I'm not going to spend a lot of time on hormones. But one of the biggest things that you can remember with the hormones, the progesterone, when we release that, it helps smooth muscles. Well, the uterus is a smooth muscle. So you got to think of that as why we have progesterone in our body is helps relax the smooth muscle. So that's working more after you have the baby. Okay. But estrogen is that major hormone that helps us with uterine contractions. I've also posted this up here for you so you can read over that. The one thing, I don't know why when I posted that I had to type in the words there. But I want you to understand that with these different hormones, they all work together, and the major goal of them is to make the uterus contract. Because with the uterine contractions, I am able to, or the patient is able to dilate the cervix, efface their cervix, and move that baby's station down to be delivered. Okay. So I'm not spending a lot of time on the hormones there. Our psych, guys, this is a very scary time for patients, particularly our first-time moms. We see lots of fear and anxiety and excitement, but I think it's the fear of the unknown. So we need to make sure that we keep this patient as positive as we can and help them with the different fears and reassure them that things we're doing everything that we can possibly do. And I'm going to talk more when we get into, I mean, you guys know how to give patients support. The other thing that's really sad right now is, you remember when anybody in your family ever had a baby? I remember when I had my daughter Ashton, which she is 30, how is she, 32 or 31? One of those ages. I can remember, and I look back at the videos, and everybody and their brother was at the hospital. I've got videos of my daddy in the waiting room smoking a cigarette while he was waiting on his granddaughter to be born. And there was probably 50 people there. Now people can't go in. And it's sort of, I think it's good. I've got to look at it positive too, is that mama and that daddy need to bond with that baby first and not have all these other people. But I remember how it was. Everybody wants to go see the baby. So some moms are having a little bit of just upsetness because their family members can't be there. So that's an added issue with what's going on with this. Another issue with COVID. Okay, so let's talk. I'm trying to figure out how far I'm going to go before I'm at 12:27. So if I go 10 more minutes, will that be good? And that way that your break was 10 minutes and you can go. Okay, will that be good?
Yes. Yes.
I am doing pretty good. All right, so let's look at our things that are going to bring labor on. I'm not sure exactly what all Miss Hicks talked about. Did she talk about lightning? Do you understand what lightning is?
No.
Okay, good. All right, so sometimes I just want to make sure I'm not covering something twice. So lightning is one of those things that you can actually see, or moms see it more, I think sometimes. It's when the baby is moving down into the pelvic area. Most of the time babies are up and they're moving around. And remember when we talked about the different pelvics, one of the first things that starts happening is that baby's got to start making its way down to the pelvic inlet. Okay, I want to make it start. Some moms will say that they can put their hands underneath their breast and that they feel like they can, and they have room, and that they feel like they can breathe better. And sometimes we can look at moms and say, oh my goodness, you have dropped. Have you ever seen somebody that was pregnant and you were like, oh my God, you saw them one day and then the next day it looks like the baby is getting ready to come out. So that is not something that we run to the hospital for, okay? This can happen really, really, I mean, sometimes up to 3 and 4 weeks prior to the delivery. So dropping is called lightning, and that's when the patient actually notices there's a little bit more pregnant or pressure in their bottoms. Another thing that's happened is Braxton Hicks. The difference in Braxton Hicks and the contractions of the forces that are going to make the cervix dilate is these contractions don't make the uterus or the cervix dilate or thin out. Okay, so Braxton Hicks, I think of it like this. If I'm getting ready to go run in a 5K, y'all know I don't exercise, so you know I'm not going to run in a 5K. The uterus is trying to prepare themselves or to train themselves on what is getting ready to happen. So it has those little contractions and saying, you know what, I hadn't done this before. I'm not sure what I need to do. I'm going to see if I can do this before. So when you train for a 5K, you don't just go up on the day of the 5K and say, okay, I'm going to run this 5K now. You don't do that. Well, your uterus doesn't either. But the biggest thing that you got to remember with the Braxton Hicks is it's very irregular. So the patient's not going to have contractions like 2, 3, 4, 5 minutes apart. They'll have one here, they have one there, they have one. And they really, when they first start, they're not really uncomfortable. But as you progress into labor, getting ready to, you will notice they will become more uncomfortable. But then it's not, Braxton Hicks contractions don't have the ability to change the cervix. They will not be able to thin the cervix out, and they will not be able to dilate the cervix. So the other thing that we're looking at is that the patient cervix has to, when we talked about it and we showed that it was long, thick, and closed, did you know that I said thick? We talked about a face, but I said thick. Because why do you think it's thick? It's got to protect that baby from the outside world. So as you start going into labor, that cervix becomes softer because I need it to be softer to be able to open up and be able to thin out. So you can hear patients say, well, I went to the doctor yesterday and he told me that my cervix wasn't ripe. And what he's meaning by that is that it's not soft. And until that cervix becomes soft until it becomes ripe, there is no way that cervix can dilate or thin out. So there's sometimes that we have to bring patients in that their cervix is not right, that we have to give them medication to assist them in getting the cervix right so they can dilate and efface. Because that might be the beginning of it. The other thing that we talked about was bloody show. Remember I said there's a mucus plug that forms in the cervix during pregnancy that will become expelled. So the way I look at it is there's two barriers to the outside world from this baby. One of them's the mucus plug and one of them's the membranes. And the membranes is the sac of fluid or the amniotic sac. So when both of those are broke or the mucus plug has come out, that could be the beginning of labor, but don't get your hopes too high because it may take 48 hours to get you to start going into labor. So, and we'll talk about the rupture of membranes now. So that's another, some mamas can pop their bags without being in labor. But when and I've got to make you understand this for everybody that you know that's going to have a baby or for testing purposes or whatever you want to say, when that membrane has ruptured, I need you to picture in yourself that mucus plug is gone and the bag of waters is gone. So the protection of that baby is in from the outside world is broken. I need to get that baby out within 24 hours. So we have got to put a lot of education on this mom. Don't wait. I know so many moms, their membranes rupture and they're like, but I'm not in labor. I'm not contracting any. And they wait and they wait and they wait before they go to the hospital until they get into a pattern for their contractions, and it may not happen, and that's wasting time. Why do you think I'm so concerned about that?
Infection,
absolutely. The barrier from the outside world is broken. This baby can develop infection, mom can develop infection, and I don't want to take that chance. So we have got to educate our patients to make sure that they know as soon as that, even if you're not having any contractions, as soon as that water breaks, by golly, you better head on and get it together. Another thing that we see is a sudden burst of energy. Have you ever heard anybody say, I'm nesting?
Yes.
They get this sudden just burst of energy, and they start washing. They've already washed all the baby's clothes anyway, but they wash them again, and then they fold them off, and they put them up, and then they wash them again, and they do this and they do that. And I try to tell moms, please don't do that. You're going to wear yourself out, because if they keep on doing all this stuff over and over and over again, by the time the birthday party starts, they're going to be exhausted. So tell them that do a little bit. I did the washing of everything and folding it 25 times. But when I went into labor, I was not tired. So you've got to tell them they've got to take that easy and do that.
So is it just more so to conserve the energy for labor? Okay.
Yes. Conserve energy. Absolutely. That's the biggest thing. Not that I'm telling them they can't wash their kids' clothes, but if they stay up all night, washing and folding and doing all that stuff, they're going to be exhausted.
Mm-hmm.
So I need them to save their energy. And telling a pregnant woman to quit doing that is like talking to that wall back there, because they're so excited and they think that baby's getting ready to come, and they get excited. So the other thing that we're going to see is, had to click your finger, happy finger. The other thing we may see is weight loss. A lot of moms don't feel like eating a lot. They feel bloated because their baby's getting big and stuff and all those hormones going on. But it is vital that we make sure that they understand that they need to keep themselves hydrated. Now, as soon as they come into the hospital, we'll probably start an IV on them and give them a little bit of fluids, but make sure that they are not forgetting that they need to drink a lot of fluids. So those are some of the preliminary signs of labor. I do want to talk about true labor and false labor. And then after I talk about that, then that's going to be a perfect place for us to start on Monday. So the biggest thing with true labor, remember our goal is for that patient to have dilatation and effacement of their cervix, to have regular contractions. Remember, what do we assess in contractions? Frequency, duration, and intensity. And sometimes the pain starts in the back, but the difference in true labor and false labor, true labor is going to dilate the cervix and efface the cervix. With patients that are in false labor, there is no dilatation of that cervix and no effacement. So that is what tells us the difference between true labor and false labor. True labor, you have cervical dilatation and you have effacement. You have regular contractions. You have a pattern. With false labor, no effacement, no dilatation, and their contractions are irregular. There is no pattern there. And most of the time, when you get up and walk and it's false labor, they'll stop. In true labor, it's not going to stop. When you get up and walk, or you get up and change positions or whatever, it's not gonna stop. It's gonna continue, because you're gonna be very, very uncomfortable. A lot of times I'll tell people when they call and they're like, I'm not sure if I'm in labor or not, I would tell them to go take a hot bath and just relax a little bit. And if the contractions stop, then I know they're in false labor. But if the contractions continue, then that tells me that they may possibly be in true labor and then they need to come to the hospital.
I have a question.
Yes.
About telling the pregnant woman to take a hot bath, because I know that they have increased blood flow and vasodilation and stuff like that. I don't want them to pass out. So is hot bath appropriate, or can I just tell them like lukewarm or something like that?
They can take a hot bath. I don't want it to be hot tub hot.
Right.
Okay. Don't go get in a hot tub. Absolutely not. But you can, I don't want her scalding herself with the water, but it can be hot water. You don't have to sit her in a cold, lukewarm water. It can be warm water.
Okay, thanks.
Mm-hmm. All right, so that's all I have for you guys this morning. Now questions.
Mine's not really related to this, but so for the peds sim tomorrow, for those of us who have that, what all should we bring?
I was trying to think or see who this is talking to me.
I'm Hannah.
Oh, I can't see where you're at. Okay, there you go. Peds sim, all you need tomorrow is your prep and an IV start kit.
Okay, perfect.
Will you have the recordings posted today?
You know, I can try. I have never done this before. Does anybody know? I'm trying to think. Okay, it says it's still recording here. Okay, pause recording, stop recording. So what happens to this when I stop it? I don't have any idea. I'm going to do the best I can. How about that? Okay, I'm going to pause it right now. And then I'm going to wait till y'all start getting off and stuff, and then I'll try to see what I can do. I've never posted this like this, so I hope that I figure it out. Okay, so anybody have anything, all the good times, indoor smoking and no face masks. Yeah, my dad, I got the video of him just smoking. It was crazy. All right, I'm trying to think. Here's a good picture on. Okay, is the baby spine up? Now I have a fundus. Okay. So does anybody have any questions of me before I go? If not, I will see you guys. Those of you that are coming to.
Thank you, Miss Walker.
You're welcome, baby. Those of you that are coming to Peds with me tomorrow, I will see you in the morning. Don't forget your IV start kits, and I will be down to start checking you guys in about 10 after 8. Okay.
Ms. Walker, I have a question, just so I'm letting you know today, because I have Peds with you. That's my last rotation. That's after Thanksgiving. I'm going to look at my old clinical bag. I'm not sure if I have an IV start kit. I'm not sure.
Okay. I think I might. If somebody on the last week has 2.
Okay. I'll double check.
Yeah.
Okay.
Miss Walker, I'm also going to need an IV start kit. I had to use it for my dressing change.
Okay. Yeah.
I think I'm going to need one too, because I just looked at my bag and I think I used it from checkoffs.
Okay. Yeah, I should have enough. If not, I will do what I can to help. What is the unit of measure for the different stations? What are you talking about? Elaine, I don't know what you're talking about. Different Catherine, I have already put up the OR. Those of you that are going to OR tomorrow, something came up and Miss Sugar cannot be there tomorrow. So I want you guys to, you have your assignment. Who's going to the OR? Because I want y'all to be there Friday. My sister-in-law's having her knee replaced, and I want somebody to go in there with her and say, I'm Miss Walker's student. So y'all need to go in there and take care. So I'll make sure that she's okay, because they won't let me come.
I'll go in there with her.
Okay, Madison, just tell her if you get to go, just go say, I'm going with, her name is Trisha Price. So you go take care of her and let me know she's going to be okay.
Okay.
And she'll give you permission to talk to me about her. So we won't be breaking HIPAA. Okay, what is the unit of measure for different stations? To go through -5 to -4, is there a finger breath or like, I think it's not really, I don't think it's a centimeter. I think that's just, ugh. I don't know that we actually give measures, like a measurement like that, Elaine. I'm sorry. It's just in relationship to the ischial spines. Oh, sorry, I don't have like a measurement. All right, did I answer everything else?
Where did you say the assignment for OR clinical was for tomorrow?
It's on Swift River. It'll come up.
Okay.
It'll come up tomorrow.
Okay, great.
It has to be done tomorrow.
Okay.
All right, any more questions? If not, I'm out of here. Bye, guys. I'll see y'all Monday.
Bye. Thank you.
Bye.
Uh-huh.